With joy and with pleasure, I welcome you all to the second National Mosque PCOR 2021 two-day symposium. This is our last session of the symposium. Well, it embarks as it ends one project, but it actually embarks the next project, and we are looking forward to the future with this, especially with this particular session that we are hoping to align the ducks in the row. So we are finishing up a project called Equipping Muslims with PCOR-based action-oriented research tools. There were three collaborators in this project: Pastors for PCOR, Worry-Free Community, and Initiative on Islam and Medicine. Over the past 2 days, you have heard from all of us, and we had lots and lots of things to share, lessons learned, some didactics, methodologies, and many good things came out. And I personally enjoyed it. I hope you enjoyed it as well. But this session is very special for us. And today we have with us Courtney Clyett, who would be presenting to you the PCORI itself. She's a representative of PCORI, and she's the program officer who has dealt with us almost on a regular basis throughout this past year, coaching us and guiding us in the PCOR ways of conducting community-based research. Courtney, allow me to introduce Courtney. She has a master's and she's a public health and project manager. Her focus and professional expertise is public health and project management. She's studied in international politics and global health design, monitoring and evaluation. Her focus is community building and engagement. And she has extensively worked with CBOs in the District of Columbia and provided with program oversight and technical assistant. A couple things I got to tell you about Courtney. I have seen her coaching other, or I have seen her listening and to other community-based organizations, as I had the pleasure to be to attend a panelist discussion with her with the other community-based organization, and she listens intently. She is an active listener, and because of that, the skill, she is very much in tune with what the community members are doing, and she listens in multiple ways. Actually, I have learned how to listen from her. That's not only that, she has taught me PCORI methodology, but I'm also learning how to listen. And she would say one statement or a few statements, and that literally changes your entire course of action. And I'm thinking, she has this power because she's a funder or the funder's representative. And I thought through this, and I said, no, that's not the case. She has become a funder's representative because of these qualities. That's how she interacts, and she guides you through the process. It's an amazing, it has been an amazing journey with Courtney. And Courtney, of all people, I'm going to miss you definitely after this project. If I miss nobody, but I definitely miss you. I got to share one other aspect of this, and that's literally that phone call changed my entire ways of thinking. And in fact, that this project is a result of that phone call. During our eMarch project, it was our third call with Courtney. We have calls on a monthly basis with program officers to see to do monthly check-ins to see whether we are on a course or what kind of help we need, the assistance. They have many resources, and they provide a lot of assistance to us. So after this call, as soon as I hung, I said, "Oh, Courtney corrected me 3 times." She said, "You mean CBPR methodology, PCORI methodology?" I said, "I kept telling PCORI approach, and she corrected me 3 times, saying, 'You mean methodology.'" And it just clicked. I said, "Wow, this is a methodology and not an approach. So PCORI is a methodology." And as soon as my brain translates that, I Googled PCORI methodology, and I actually see a methodologies document. And I've been into the eMarch project for about a year by then. I'm like, duh, that's where the secret lies. It was like a map to the treasure island. That's what it was. And I said, okay, this is it. So that's how she works, and she really has the power to change the way we do research, the way we conduct and engage. So PCORI, with PCORI, it has been a pleasure, and with Courtney, it indeed has been a pleasure to ride on this journey. And with this enthusiasm, I really welcome Courtney to be with to be with us to share. Oh, I lost my screen there. To be with us today and to share what PCORI has for us in the future. Welcome, Courtney. And the floor is yours, but I have to get your PowerPoint up and running. So hang in there just a minute, and let me see if you guys are seeing what I'm seeing.
I'm still seeing myself, which...
Okay, so I need to see what is PCORI and how can you get involved. So I probably need to switch it right there.
Nope, now I'm seeing me. And so Fatima, thank you for your willingness to run through the slides today. I was sharing prior to this that I did not want to be the one who displayed my lack of technological abilities. So I did not want to have to advance my own slides, and she kindly agreed to do that for me. I'm still not seeing the slides. I'm only seeing myself, but that's okay for the moment because I can still talk through them. And also just thank you so much for your very kind words about my work and how I have worked with you guys over the last few years, you and Dr. Padela. And it's really been a pleasure and an honor to be with you in the development of your project, and also to see how the evolution has happened from one project to the next. And there were, Michael was on a little earlier talking about his project with the Somali community in Minnesota, and I worked with them as their program officer on that project as well. And so it's always a great feeling when you can see that one thing has matured out of another and then out of another. So let's see.
Can you guys see the slides?
Not yet, Fatima.
Oh, really?
Yeah, you have to click the window or the tab.
That's what I did. You know what? Let me go to the window tab. Maybe that would be the best thing to do. So now can you see the PCORI slide?
Still not. Let me see if it'll let me do it.
Okay, you can just play now.
All right, is it up now for folks?
Yeah, we could see it in the non-presenter mode.
Okay.
Oh.
So I think
Courtney's sharing.
I think I'm the one who's sharing it. So give me a second. I told y'all, technological challenges, right? So let me go back to that window and put it in presenter mode. Let me see. Now it's taken away everything else that I had. So give me a second. All right, and what are you seeing now?
We are seeing the presenter mode, but I think the transliteration is on. So you might want to shut that off.
Now that I don't know how to shut that off.
Okay, that's fine. I think people can. It's just recording what you're saying and putting it at the bottom of the screen.
Okay. All right. Well, I'm just going to go forward then. So let me see if I can come back up here and go back. So hello and thank you again, Fatima, for the introduction that you provided. And thank you to the project team who've made this virtual convening possible. I'm pleased to speak with you today and tell you a bit more about the Patient-Centered Outcomes Research Institute, where I work. And you've heard from several people about PCOR and the work that they've done with PCOR. And then I'll be telling you a bit more about how PCORI is different from other research institutes and how we do our work, and also how we were funded. So next slide. So PCORI is an independent, non-governmental, nonprofit organization authorized by Congress in 2010. PCORI funds comparative clinical effectiveness research, or CER, that engages patients and other stakeholders throughout the research process. It also supports work that will improve the methods used to conduct such research, like patient and stakeholder engagement. So that methodology that Fatima was speaking about earlier really is around, parts of it are around that piece of patient and stakeholder engagement and using that as a methodology and not necessarily as an approach. And so the efforts that we support seek to answer real-world questions about what works best for patients under their own given circumstances and concerns. And so, you can acknowledge that for all the advances it produces, traditional healthcare research has not answered many of the questions that patients face. Folks want to know what option is best for them, and patients and clinicians need information that they can understand and use. And so PCORI seeks to support efforts focused on answering some of those questions and providing the information that's most useful to patients, clinicians, and other stakeholders when making decisions about their healthcare. And on occasion, patients may ask, when they're presented with treatment options or diagnostic options, well, what should I expect will happen to me? What are the options or potential benefits or harms of those options that you're presenting to me? What can I do to improve my outcomes that are most important to me? And then clinicians may ask, how can I use what you have created in research or your research findings? How can I use that in my daily practice? So patient-centered outcomes research really focuses on the patient perspective and including patients in developing research priorities, research agendas, as well as developing research protocols. So it considers patients' needs and preferences and the outcomes that are most important to them. It investigates what works for whom, and it helps patients and other healthcare stakeholders to make better health-informed decisions. PCORI's research that we fund pays close attention to conditions that heavily burden patients, families, and/or the healthcare systems, including chronic or multiple conditions, rare diseases, and understudied conditions, and then conditions with varied outcomes across subpopulations. And so you may see some of that reflected in our national priorities, which I'll share a little later. At PCORI, we believe that research can be done better when you are engaging the patient. And so by engagement in research, PCORI refers to the meaningful involvement of patients, caregivers, clinicians, and other healthcare stakeholders throughout the research process, from topic selection, as I said earlier, then to the design and conduct of research, to ultimately the dissemination of results. We recognize that when the patients and stakeholders are involved from the beginning, there's more of a likelihood that they will be more willing to uptake results, or the patient community will be more willing to uptake the results that come from research projects that people like them, people whose perspectives are maybe similar to theirs, are represented in the development of that research project. Effective engagement of stakeholders and patients does definitely require a well thought out plan. So you can't just come up with an idea and not run it through the community with whom you want to work. You need to be engaged with that community and ensure that what you hope to do is something that that community actually wants to participate in. And we recognize that engagement can take many forms and it varies with the nature of the research. So we don't require any specific activities. Instead, we do encourage that our applicants bring their most creative ideas forward when it comes to developing research projects and how they will engage patients. So engagement is one of the key pillars upon which PCORI operates. It's integral to our work and the work of those that we support. And through the Eugene Washington PCORI Engagement Award Program, the program that I work with, we support projects that build a community of patients and other stakeholders equipped to participate as partners in PCOR CER, as well as serve as channels to disseminate PCORI-funded study results. So please keep in mind that this funding is to support engagement in and with research, not to conduct research studies. So although several people may refer to their engagement award projects as studies, they are not actually research studies, because at PCORI, the Engagement Award Program doesn't fund research, and you are not comparing two different things. You may be working with a community to identify things of interest to them when it comes to developing a research agenda, or even to get a sense of their preferred method of engagement. So in this slide here, I wanted to share with you some examples of projects that have been funded under the Engagement Award Program that have focused on faith-based communities. You may see that there are at least 3 projects on this slide that are based in the Chicagoland area. So as was mentioned earlier, Pastors for PCOR, that is a project that I think was one of our initial projects working with faith-based communities. And then we had a project in Arkansas that was working with faith-based communities as well. And then at the bottom of this slide, you'll see here, the eMarch project, which then resulted with the eMPART project. So right now, we do have 3 funding opportunities available. Letters of intent for these funding announcements are due on October 1st. And the opportunities fall under capacity building, which funds projects to prepare patients and stakeholders to participate as partners in CER. The dissemination initiative, which funds projects to support communities and organizations to actively disseminate PCORI-funded research findings. And then also stakeholder convenings, which support projects to convene stakeholders to explore issues related to CER and or communicates PCORI-funded research findings to targeted end users. This slide just shows you an example of how the Engagement Award projects fall under the research process. So we, as I stated, support projects that help to build partnerships to identify research priorities. And then ultimately, some of those projects can then go on to work with communities to disseminate findings from PCORI-funded research. And just to talk a little bit more about our Engagement Award program, our Engagement Awards have supported awardees by empowering stakeholders to continue active roles and pursue additional opportunities with PCORI or other research institutions. We do recognize that many of the tools and resources that have been created by our awardees may be useful to others. And so we've created what we call our tools and resources repository. And I've provided a link at the end of this slide deck for your reference. Instead of recreating the wheel, it's better to sometimes be able to look at what's been done, what's successful, and then also be able to adapt that perhaps to your particular community. So next I'll be sharing with you about PCORI's growing research portfolio funded projects. And to date, we funded, well, actually, this is as of March. There was not a more recent slide, but as of March, we funded nearly 1,800 projects for more than $2.9 billion. We funded projects in 49 states. You can see here that North Dakota is still blank. We're still working on that with some targeted outreach. This slide here just shows you some of our most studied conditions. The top 2 are mental health and cancer. And then going a little bit more into our national priorities, this is a list of our national priorities. They will likely change in the near future. We had a public comment period for our new proposed national priorities that closed on August 27th. And we expect to finalize them by fall of this year. And then we anticipate that our finalized priorities will serve as the foundation for our upcoming research agenda for years to come. This slide here just gives you some examples of how we engage our stakeholders. And next, I'll share with you how to get involved with PCORI. So you likely heard from Janice this morning about some of the benefits and the impact of being a PCORI ambassador. So I won't go into too much detail, but you can certainly reach out to her. I'm sure she'd love to chat with you. But our ambassadors at PCORI are really like our boots on the ground. They're working within communities to ensure that there is some sort of knowledge of PCOR. Again, sometimes you have to change mindsets for people to really understand that you want to hear their voice and that they deserve to have their voice heard in the development of research projects, because more than likely they will be the community that will be most impacted by the results of those funded projects. Let's see. Next we have, I think next is merit review. Yes. Next is our merit review. So this is another way that you can get involved with PCORI. Our merit review is the process by which PCORI determines which research projects it will fund. And our merit review panels usually include scientists, patients, and other stakeholders. And the idea is to bring a diverse perspective to the review process. So generally, each research application is assigned to 3 scientists, 1 patient, and 1 stakeholder. And there's often an external scientist who serves as the chair of a panel to facilitate that discussion. So the requirements of scientists include an advanced degree in health or a research-related field, relevant peer-reviewed publications, and an active research program in a relevant field of study. And for patients and stakeholders on a merit review panel, they will be expected to contribute their own unique healthcare system perspective, as well as their lived experience. And on this slide, I just wanted to make sure that you're aware of a a training opportunity that PCORI has made available. It's called Research Fundamentals. It can be found on our website. It is a learning package that allows you to move at your own pace. And I can go over some of the objectives of that. So the objectives include increasing stakeholder understanding of PCOR-CER and basic research principles, enabling all team members to understand their respective roles and contributions and assets, and then also enabling all team members to obtain skills and learn behaviors to work successfully team environment, multi-stakeholder team environment. And PCORI has also recently created a resource called Best Practices in Multi-Stakeholder Team Science. That can also be found on our website under engagement resources. And this slide here just gives you some additional links to ways to get involved with PCORI. And so at the top of it, I've referenced the PCORI advisory panels. Each of the program areas at PCORI have an advisory panel that informs them and advises them on the work that they are setting out to do for the year. And each of the program panels have openings and an application process, usually that closes somewhere around the spring. So I'd encourage you to stay tuned for spring next year. And you can certainly click that link there to see if there are any openings on any of the available panels. And then we have our peer review process, and you can find out more information on the PCORI website. You can also find that link to the engagement tools and resources repository that I mentioned earlier. Several of our applicants, as well as awardees, have found this link to be really helpful when it comes to creating new project ideas, or even in the implementation of their current projects. They've realized that there may be some tools that other people have created that could be of use to them. And then lastly, at the bottom of this slide is a link to connect to PCORI or to subscribe to PCORI's newsletter. That will allow you to stay informed of any funding opportunities and any upcoming events. PCORI's upcoming annual meeting will be virtual this year, and that will be November 17th through the 19th. And so I encourage you to also go onto our website and submit an application to attend. And I think that may be the end of my slides. Yes, it is. So this is my contact information here. And then I'm done. So I will stop sharing. All right. So I'm done chatting for the moment. I think, though, that we may be facilitated, or this session may be facilitated by Dr. Padela. So I will turn the mic over to you, and I'll mute myself, and you let me know when to unmute myself.
Thank you, Courtney. Go ahead.
Thank you. Yeah, I think Fatima's still hosting, so I'll let her drive the car.
Okay. We will just a couple things that we would do: set up the stage, and then we would have an open panel of discussion. But before we go there, I would really like the panelists to introduce themselves. But let me actually share with everybody who is going to be on the panel. And we actually, unfortunately, because of the platform, it doesn't allow us to have everybody on the discussion at the same time. There were a few other people who have been wanting to join, and they would be joining with us on the chat. So I'm hoping you are seeing yes. So let's actually start the panelist introduction. And as much as I would love to introduce every one of them, but we want to hear from them. So as I advance the slides, I'm hoping, or why doesn't everybody, they would come in and introduce themselves. That I would begin with Sister Sundas.
Well, greetings of peace, everyone. My name is Sundas Saad, and I'm currently an adjunct assistant professor at The Ohio State University. And my passion has always been into women's health, which is a special population, and that's where my patient cohort that I like to focus on. And being a visibly Muslim, I believe that's how I was cornered into so many organizations that caters to Muslim populations as well, which is really humbling and insightful experience to be done in the American platform. I'm part of so many NGOs, and I'm fortunate to be part of the Initiative on Islam Medicine board for the last over a year. And luckily, it seems like Fatima is working hard on pulling me into the Worry-Free Clinic, which is the Midwest platform. And I look forward to being of use. And thanks a lot for everyone who introduced their work for the past day and a half. Currently, for the faith-based community contributions that could be relevant to the PCORI platform would be the mental health, the Muslim Mental Health Aid, which is a framework that pretty much implements most of the tools that all of the respectful panelists have introduced over the past day and a half. So I look forward to presenting that at some point. Thanks a lot for having me.
Okay, this is Fatima Mirza, and most of you are familiar with me because I've been talking for the past 2 days. Thanks again for listening to me. My name is, I run a nonprofit organization called Worry-Free Community. We started with access to care problems or addressing access to care problems in the community. And now we provide health coverage enrollment with to about over 5,000 people in the greater Chicagoland area. And in fact, we actually are now getting calls from multiple states. So our work has gone over 15 different states, and we help the Muslim community out in that, with that respect. So essentially the access to care delve into the social determinants of health, and that's how I got involved with the eMarch project and with the EM Part now. But really, I do personally believe that PCORI is the way to engage and to it's a tool. It's a really beautiful tool and a very, very powerful tool to address any of the community health programming. So with that, we would move on to Dr. Safdar.
Thank you, Fatima. Thank you all for having me. My name is Nabil Safdar. I am currently professor of radiology and biomedical informatics at Emory Healthcare, where I'm the vice chair of informatics in the department and the associate chief medical information officer for Emory Healthcare. I did my MPH many years ago in assessing the barriers to healthcare access in the Muslim community in Maryland, which sparked my interest in and my first exposures to being involved in the community, which I was a part of, and opening my eyes to a lot of the barriers to healthcare that they experienced. I'm the immediate past president of the Islamic Medical Association of North America and a current board member. Imana has been proud to have partnered with Fatima and the Worry Free Clinic, also Dr. Padela in a lot of his research programs that he has led, and has been a great resource for the entire national community in the past. In recent times, Imana has helped provide a lot of education online on COVID-19, mental health issues, even recently sexual health issues through its education committee and programs nationally, and helped to bring together the National Muslim Task Force on COVID-19. Thank you.
Good afternoon. My name is Mashid Hassan. I'm an internal medicine doctor by training. The last 20 years I've been in suburban Milwaukee. The last 5 I've moved over to the hospital side as VP for Medical Affairs, the Chief Medical Officer for a small community hospital in suburban Milwaukee. I've also had the privilege of serving on the executive board for our local mosque here in Milwaukee for 10 of the last 20 years. And most recently, I've also had a chance to serve on the school board for the district that both myself and Dr. Padela's kids go to. So it's been an interesting experience from a community service standpoint.
Brother Imran,
You're muted, Brother Imran.
would you like to introduce yourself? Okay, are you ready? Why don't we come back? We'll have, is this Shazia?
Good afternoon, everyone. I'm Shazia Buggs. I have an undergraduate degree in biology from the University of Pittsburgh, and then I decided to pursue my law degree at Northern Illinois University College of Law. I've been practicing for a little over 10 years now. I first became aware of Worry Free Community in PCORI because my daughter was a med student who I believe you probably saw earlier today on the panels. She's currently a resident physician, Hedin. She is a community health worker for Worry Free, and then through her, I was introduced to Fatima, and I was involved with some of the confidentiality disclosures and such on the Worry Free website, and so that is how I became involved. But I am, here in the Chicago suburbs, and I, having an awareness of what Worry Free is doing, and also the, PCORI's involvement with Worry Free. It's something that, as an attorney, I see everything from. I work with a lot of legal aid in organizations, so I guess Worry Free is more like a parallel to the healthcare side of that, and I'm happy to be involved and able to help in any way I can. And thank you for the opportunity.
And I must add that Shazia has been instrumental in getting our MOUs in place and data agreements, and so it has gone through her, and it was under her legal advice that we actually put we put a virtual outreach platform in the lockdown mode, and I just did not feel comfortable doing things without a legal advice. So she was instrumental, and she has gone through some of the PCORI training with us. So it's relative. This is a relatively a new domain from the legal experts that we are now pulling into our community health work, and because I strongly feel that kind of transparency is needed in order to move forward. And last but not the least, Brother Imran, I think. There you are.
Can you hear me?
Yes, we can hear you.
I'm not in a Verizon ad right now. So, okay. Thank you so much, Sister Fatma. My name is Imran Khan, and I am an IT professional by profession. I have been doing consulting work for the last 15 years, currently working with a company called Accenture. And mostly my work is around infrastructure, cloud, and migration data to the cloud, and enterprise architecture work, basically. Happy to be here as a panelist. Thank you so much.
Now, with that, we actually move on to our questions and the question of the day. So we have heard from Courtney about the national priorities. Let me actually try to play that video if I can, because then it would bring everybody on the same page. It says local video. So I want to play this video. Let's see if you could. No, it's not going to work. Anyways, it's a small video at PCORI's website, which I wanted to actually share that with you. I couldn't download it onto my hard drive, but it looks like the platform doesn't allow me to present it through that. Anyways, you can go to PCORI's website and look for National Priorities for Health little video, and it would give you that. There's a document that I have shared with all of you about the details of what are it's still a proposed national priorities, and as Courtney has mentioned, they have gone back to the drawing board and hashing out the details. So in a nutshell, this is what we have today that we are looking into, and the question of the day is how mosque community leaders can incorporate PCORI's national priorities for health with ongoing mosque community health projects. And in fact, with this slide, Dr. Padela, I want to leave it up to you. How do you want to run this? So I can toggle back and forth between the two slides.
So I think, thank you for that introduction. And what we want to do, I think, for this panel is to have a conversation that demonstrates the fact that different perspectives can lead to greater knowledge and understanding. So I know that we all represent different sectors. Obviously, we have the voice of PCORI through Courtney here, but these are the priorities that they've came up with, or they're proposed still, but these are the ones that they're going to kind of fine tune at the end of this year. So the open public comment period has stopped. However, I think that we can still think about these in terms of how they relate to the Muslim community, how the different sectors and the different stakeholders in the Muslim community that you all represent. Contrary to what I said before about when you create a community advisory panel, you can only come with one hat. In this sense, you all wear multiple hats, and it's important for us to get a sense of what those multiple hats are as you comment on these priorities. That's one. And the second, and think about them, right? So I want you to digest them and think about them. I'll read them out in a second. And the second thing is to get to the question that Fatima just said, right? So if you were going to speak from your experiential knowledge or your intimate knowledge of mosque communities and mosque community leaders, and you've heard about today mosque-based PCOR, how can we think about these things in the existing structure of health work, or the culture of health in our mosque communities? Those are the questions. I'm a moderator, so you're going to speak, and everybody will have their viewpoints, and I might follow up with a question or two or make you clarify something so that we get a greater understanding. But my role is not to deliver any content, thankfully, to this. So I'm going to push you a bit here and there just so that we can get on the same vocabulary or understand better, but that's it. So let me go back, if you can go back to the last slide, Fatima, just so that we're all on the same sort of platform for a moment, or the foundation. these are the 5 priorities. And you got a document earlier that has more detail than this, but these are the 5 sort of larger domains of the national priorities for PCORI, hopefully for the next 10 years, right? Increased evidence for existing dimensions and emerging innovations in health, enhancing the infrastructure to accelerate patient-centered outcomes research, to enhance the science of dissemination, implementation, and health communication, achieve health equity, and accelerate progress towards an integrated learning health system. So these are the 5 goals. And now again, thinking about where you sit and the multiple hats that you wear, how do you think about this applying to the Muslim community? Again, right? Or how can the Muslim community then be involved with it? So those are the 2-part questions. I will let whoever wants to start off the conversation, and I'm simply going to moderate. And Courtney is here as well to participate. So Courtney, I'm going to not allow you, but I'm going to invite you to actually help clarify, because this is also knowledge formation for the group here, right? So if there's something that they don't quite get or they're missing the point, please help correct that, since you're intimately familiar with what this content is behind each one of these larger domains. So whoever wants to go on the panel can go.
So when, may I?
I'm comfortable, one second. I'm comfortable with silence. I was a focus group moderator. I'm trained. So you all can stay back, but let the conversation happen. I'm not going to call on you all because I don't want you to make uncomfortable, but this is your role. So we don't want to fill in space. So go ahead, please.
Awesome. I'll jump in because I'm uncomfortable with silences, unfortunately, for me. Even though I've been involved with some small groups as well. But I'll tell you, from my experience, whether from Imana or from my local Muslim communities that I've been a part of, I think all of these could resonate in different ways, whether with mosque, leaders in the community, or leaders that have more informal positions of leadership. There's a lot of informal leadership which is exercised in our communities, or nonprofits for that matter, that operate in these spaces. But to me, just on first review, the ones that I think would resonate a lot with members of our community are the 3rd and the 4th bullet points: achieving health equity and advancing the science of dissemination, implementation, and health communication. And the reasons I say that is, first of all, for health equity, in my experience and research, the Muslim community in the United States is a tale of 2 cities. Those that have exceptional access to healthcare are very well connected in healthcare, and those who have very poor access and very poor understanding of how healthcare is accessed and how to get preventative care or critical care, acute care settings. So health equity, and that often does correlate with specific demographics or protected classes, life experiences. It's a very diverse community, as you all know. We sometimes have one particular demographic in mind when we think of the Muslim community, but it's much more diverse than even people in the Muslim community themselves may recognize. And then the other is the science of dissemination, implementation, and health communication. And the reason that I think would resonate is because so many of the critical conversations that we need to have in our communities have, particularly in Muslim communities, practicing Muslim communities that are mosque going, there's a lot of stigma around these issues. And I'm not sure we've really figured out how to get around those stigma, areas of stigma, how to leverage technology to be able to facilitate those conversations, how to create safe spaces for people to talk about mental health or sexual health, or preventative screening, breast cancer screening or pap smears, or things that for some, or substance abuse issues, for some reason or another, are issues that our community is sensitive to, and in many cases averse to talking about. And so I think those are two areas of great opportunity for our community in general.
Thank you, Nabil. So I'm going to, he just mentioned some things that are near and dear to your heart. So I'm going to allow you to jump in.
Thank you. So I will try my best actually to simplify terms because this is the strategy that seems to work. I would have to say that language barrier is one of the biggest things that I find even these priorities to be stretched beyond what reality can allow. It reminds me of the experience of Healthy Objectives 2010. It was very optimistic, I would have to say. So I think achieve health equity for should not even be an outcome, with all due respect. I think it should be a journey, and I don't think it can be achievable. So I'm not really sure that it's a realistic goal to start with. Nonetheless, I think we should consider that faith-based community is a matter of health equity, as I see women's health as well. And I think that's how I find them both interconnected. And that's where I even it would be really interesting to say that I was way more interested in women's health, and because of the similarities between the deeply rooted inequity issues in the treatment of women globally, I saw the same thing with faith-based communities, right? So I believe I am more inclined to say that potentially enhancing the infrastructure to accelerate PCOR might be an area where faith-based research can start. And I believe that dissemination or implementation potentially is very difficult if there is no true collaboration amongst faith-based organizations, and if there's no community advisory board, which I believe was brought into to our attention in the second session with Dr. Padela today. I believe if there's no umbrella to take these strategies forward, it will be very difficult to achieve dissemination or implementation in faith-based communities. I think one of the also attached, I don't want to say myths, maybe one of the things that we see in the type of work that religion or faith brings into the scientific table is that we think religion brings in chaos and mess. And until we externalize that kind of notion and treat it, it will be very difficult truly to root for faith-based ethics or approach in a secular healthcare system. And so before I think we say that we want to increase evidence for existing interventions, I think faith-based communities, at least Muslim population, are not there yet. So that I find this priority is not really inclusive of Muslim communities, as the type of steps or the number of steps that we have to go is first we need to create the evidence and generate that. And that's why an institution like Initiative of Sound Medicine is of substantial value. And then accelerate progress toward an integrated learning health system that also falls under community advisory board. And that's where I see faith-based communities get stuck if we don't externalize the myth of faith equals chaos. And second, find an umbrella under which faith-based communities find a comfortable, genuine, and authentic space to function, to create infrastructures. Thanks.
Thank you, Dr. Sons. There was a lot of content there. Anybody want to add, build to that?
Sure, I can address not necessarily the concern, but the comment related to the achieving health equity. It is a lofty goal, but I think if you read a little bit more about what the statement says, the achieving health equity, for us, it's an advancement from where we were before. We're just addressing disparities. You're addressing disparities and letting the disparities continue to linger. There was some verbiage around perhaps eliminating disparities, but then it was like, yeah, that's probably not necessarily going to happen, right? So the idea is to achieve health equity, but as you said, it is a journey. It's not something that's going to be done in 10 years, undoubtedly. So the language under that goals, or that priority rather, states that PCORI aims to advance health equity in the United States. And that, I think the idea behind having it as listed as achieving health equity is not just to say we're just going to advance health equity. Like, we are going to challenge ourselves and those that we fund to reach a point of moving forward that needle towards health equity. But I do encourage you to, as I mentioned or may have mentioned in my presentation, that there is an opportunity for public comment. And I think that everyone's perspective here would be relevant to some of that conversation. Generally it's our board of governors who will adopt and vote to accept these new national priorities. But because PCORI is funded publicly, it's the public who has a say in what it is that we should do. So I encourage you all to share any concerns you may have about some of the wording, or even challenges to tighten it up and make it more realistic to what your communities or to reflect how your communities can participate.
Thank you, Courtney, for that. I want to ask a question build on something that Nabil said, and to draw some of the other members of the panel in. So Nabil, you mentioned this notion of, on this equity topic, you mentioned tale of two cities. I think that was the expression you used, that there's a sort of there are two different Muslim communities at least, or there's many, but there's two on two opposite ends of the spectrum. But then you commented on achieving health equity. So do you think that achieving health equity in the community is the responsibility of the community between these two different, one on the high end, right, one on the low end, or is that a responsibility that others have in the national agenda here? So sticking on the achieving health equity, how do you think that plays a role with your idea that there's two different Muslim sort of communities that we speak about?
Yeah, that's a great question. I don't think they're mutually exclusive. I think that there is responsibility within the community, particularly with those that have higher level of access to healthcare, have a lot of experience or leadership in healthcare, or are in a position to help lead their co-religionists in the right way, to inform them, to lead them, to help empower them to access healthcare that they need, to reduce those barriers that were mentioned. But it's not solely the responsibility of the Muslim community. This is part of a national problem, right? This is part of the national discussion. And, whether it's at the level of a mosque or a free clinic or organizations that engage in public advocacy, it has to do with healthcare policy, how people will receive and respond to healthcare policy or changes in policy, changes to coverage, which gets messy, right? I mean, I think one of the challenges is that a lot of time mosques or nonprofits don't want to get into that. I can speak from my own experience with Imana. We have a very diverse group of volunteers, of folks who support us from different places on the political spectrum. So to get into this particular conversation requires taking a little bit of risk, and it requires having some really frank conversations. But Aasim, to your point, I don't think that I think it's a shared responsibility. I think those within the Muslim community who are in a position to really bear their advantages to advance this conversation have that responsibility. I mean, that's personally from a faith-based perspective, my viewpoint. But it's not exclusively their responsibility. It is, a rising tide raises all ships, right? So this is something that is part of that national conversation about healthcare coverage, about healthcare access, about achieving health equity and reducing disparities.
So Dr. Hassan, I'm going to draw you in as a health system or a hospital executive on that point, right? So I asked Dr. Safdar about the community responsibility now. As someone who wore a hat from the healthcare system perspective and now payer, and right, so speak to where that partnership exists and what the ways of partnering there are, and your vantage point on that conversation. And Courtney, I'm going to say something. I'm going to put this here because perhaps right after you can mention this issue, when we or address this thing. When we talk about achieving health equity, what's the model? Who are we measuring against, right? And why are we measuring against that? So, Dr. Hassan.
So I'll comment on a couple of things. I had the privilege of serving both for a more urban hospital in central Milwaukee and now also at a suburban hospital. So I've kind of seen both the tale of two cities that Nabil was talking about. I can share the experience that our more urban hospital, the second language for translation was Spanish, that we'd have to call translators to the ED. As refugee concerns started to rise in Milwaukee, our third language became Rohingya for translators. And it was very interesting. We had to now figure out, how do we service this burgeoning Burmese population of mostly Muslim immigrants that were escaping war, to better service their needs. And I think having some partnership from a hospital to mosque standpoint is very important. As I'm sitting back as a hospital operator, listening to what I've listened to the last couple of days, to me, the opportunity lies likely in engaging masjid leadership with each hospital that serves their local community with a community health needs assessment that's done, and making sure that you have a seat at the table when that assessment is going on, and making sure that masjids are available and aware that this is going on in your local communities, because I don't think that that insight is there for all mosque boards that are around. I'd also say that I think it's important to, take a step back with mosque boards just to understand that you've likely been focusing on physical plant and delivery of services for the much of your perspective, and being able to focus on both programs as a next step. This now I'm speaking as a mosque board leader, that move away from the physical plant part and now move to people, move to services, being able to offer services that are needed, that you're identifying as needs. And I think that some of the PCORI work that we're seeing here really allows some focus to be able to devote some energies to that. With regards to health equity, I do think that working for a hospital system, especially a national hospital system like Ascension, where they've drawn a clear focus on what their stance is with regards to addressing social determinants of health, but even larger than that, the structural racism in our country, and being able to address that more directly as a system, I think is important, and being able to leverage some of those resources as you can as a community partner is important to do so. If I could put my school board hat on for a second, also understand the reverse of what's going on. Because you're going to have people that are going to push a anti-critical race theory agenda and try to sweep social determinants of health discussions into that agenda, and try to remove any discussion about race out of the ability for that to happen, especially at the high school level, where you're now going to potentially reduce the possibility of motivated, energetic students that want to go into addressing these social determinants of health as an issue and a career choice. And that's going to be, I think, for us as a Muslim community, very important for us to address that we don't stand for this obstacle to addressing health equity. And we want to push back against that. And certainly, as Nabil said, there may be some variations in terms of how messy you want to get politically with that. But the reality is, to have this removal of discussion altogether is something that we as Muslims should really be, I think, more concerned that is stifling the discourse that does not allow us to progress towards achieving better health equity.
Thank you. Insightful. Others want to jump on that? Or Courtney, would you want to comment on the equity? So how do we measure that, or what's the barometer for that from a PCORI standpoint?
So I can't necessarily speak entirely to that. I was not necessarily involved in the development of these priorities. However, I will tell you that when it comes to our addressing disparities, our current addressing disparities portfolio, there is not only just a focus on race and ethnicity, there's also the focus on rural needs as well, recognizing that access to care is certainly an issue. So I think overall, when you look at improving healthcare systems and access to care, those two things are very much integrated, because if someone is in a place where they have no access to care, how can the health system work to improve that for them, or what their healthcare experience is? Additionally, I can speak to the fact that under our new legislation, PCORI was given 2 additional health priorities to focus on that include maternal mortality and morbidity, as well as intellectual and developmental disabilities, recognizing that those are also 2 communities. The birthing community as well as the IDD community are 2 communities that have had very disparate health outcomes. And so, it's really up to the public to help PCORI to think forward to how exactly, what does achieving health equity look like? Those are some of the questions that are actually asked in our national priorities public comment, to get a sense from the public, what do you think we should be focusing on? We do also ask the public to give us research topics, research ideas. And we look to the public for topic generation so that we're not just in our DC office. Well, when we get back to the office, we're not just in our DC office telling you this is what we're funding and it's because we've decided this. We want it to be something that is a public opportunity for comment to let us know what are those things that we need to focus on. Certainly, we do have teams that look at, they do horizon scanning and they look at topic synthesis. But we need to hear from outside of PCORI what the focus needs to be and what you all would then see as being the success, or what would success look like for achieving that health equity.
So I hear that it's truly a public enterprise, right? And so it's a partner, but it's open to and transparent that the public can help drive emissions, and there isn't a singular notion, right, from top down. I want to pick up on something that Dr. Hassan mentioned, Fatima, and your experience. You had talked about, well, he talked about, which I thought was phenomenal, the idea that we have to recognize from mosque communities that there's community health assessments being done by hospital systems and healthcare systems, and we should have a seat at the table. As a CBO, and where have you been, because I know that you had a very good link with DuPage County Health. How's that been part and parcel of your CBO structure?
Yeah, I was actually thinking about it. We're going to test it out in 2 weeks. Oh, so because of all the work that we have started to do with PCORI, we have made some very good connections with the independent researchers in the community, in the academia, and in the ACO domain, in the Accountable Care Organizations domain, because they need some answers, and because of all the different models that are coming out under the Center of Medicare and Medicaid Innovation, they are now recruiting participants from the different communities as well. Now, this is different than CER projects, but that itself actually is leading the payer industry. So they are much more proactive in reaching out to the community-based organizations, and I'm seeing the influx of those requests and some of those initiatives. So that's something we have started to work with. At least that would increase awareness in our community. The mosques, however, the mosque boards are basically the ones that I actually have are the ones that really need to make a connection between us and the people who are coming into the mosque, the people who are walking in. Now, it was relatively easy, outside the pandemic, that you would stand in front at the mosque door and you actually interact with the person right there, and you can tell the person as to what's going on. And at the same time, you have the board members passing by, so it was much easier to make a connection that way. But I got to tell you this: before COVID and during COVID, the challenge to engage the mosque members in the community health assessment remains. It may have budged probably 0.5% with our work. We are still and some of the times we see that the communities are ready. For example, in Al Nahda's case, they were ready to engage with us at the community at that health assessment level. Some of the other mosques, even though there's a lot of health programming that goes out, because as I love that terminology, tale of the two cities. So we do have a lot of the mosques where the members are empowered and within health systems. So they put out a lot of programs, yet those programs are do not have outcome measures attached to them. So we don't know what the impact was. So I think we need to use this principle of reciprocity and co-learning. Those are the two principles that I would be taking into my work with the mosque board members. So earlier, prior to or within this project, we've gone in with multi-stakeholder approach. I think in the next 2 years, we're going to separate out the different stakeholder types, and we are now going to use different modalities for different stakeholder types and see which one is working for which ones. So that would be my take home from this project. But I'm definitely looking for people like who are much more connected with the mosque board members, like Brother Imran is.
I think, sorry.
To help us out there.
So I think you're trying to pitch your next project to Courtney about thinking out what engagement strategy works with this type of stakeholder. So I think she's listening. But I have a question, because I thought it was interesting. We all talk for a second, Imran, I'm going to pose this to you. The last priority here is cellular progress towards an integrated learning health system. So right, and you have a background that is conducive to this notion of data architecture in the cloud systems. Data drives narratives, data empowers, data allows us to think about what we should put our priorities towards, right? So we've heard about this connectivity. Mosques don't quite potentially see their value of being community. We've heard about that we should be present. We've heard about that there's different two cities, maybe within the community. How can structures of data help us address these things and prioritize where to focus our efforts? What's your lens on this?
Right. So I think there are like political aspect of it as well, actually, because I think if that part is not taken care of and resolved, I don't think that it will ever happen, actually, right? I mean, because we've been talking about with Sister Fatma, we were discussing it the other day that if you're going to a particular medical group, basically, right, and if you have some kind of an need for specialized doctor or something like that, they don't have record of yours, basically, and probably the specialized doctor is not in that network; it's in some different network, right? That network will not talk to this network at all, right? This is a major problem that we have right now, and I don't think, and that we have talked about it, that there are so many things in the industry-wide that is going on right now from the technology perspective. There is something called blockchain data, actually, right? So you do transactions, basically. You don't need a bank for doing those transactions, but again. The healthcare is, in this, when you go to any healthcare industry, you see that they are basically in their stone ages, basically. Their servers, their data, everything is dying, actually, right? So and then when you talk about all these new technologies, then it takes it takes money, basically, to overhaul the system. Plus there are some legalities and political aspect to it, actually. So I don't know that the data is definitely there. You can mine data, you can take data from different things, but what do you make out of that data, actually, right? From the Muslim perspective as well, for the community, that what are some challenges in the communities are, basically, and what people are going through. Once you don't have that, you don't collect that data, actually, you won't be able to find, what the root causes are and what the problems are, actually. Right? So I think that integration with all these systems has to happen at some point of time. Technology is already there. We are going to Mars. It's not like technology is not there, right? But in the Earth, we have all these issues which are man-made, created, actually, and politically, it has to be resolved at some point.
So, Shazi, I want to bring you into this conversation for a second, and I'm going to build on what Imran said and kind of put a thought experiment, right? So if we have, and I'm not a legal expert, so here we're relying on your expertise for a second. Mm-hmm. So imagine a world that you had these mosque communities, right? This is what Fatma's goal is, by the way. So Fatma's goal is you have mosque communities, right, and community-based organizations that are social service and health-oriented, and they have, when the mosque community that's a congregant, in the CBO world, in the clinic as a patient. And then you go to the healthcare system, and then they're certainly a patient. But you have an ability to, cross-reference all of these data points, right, and create an integrated sort of notion that there is a human being that has social needs in the community setting. They come with you to the healthcare system. There's a CBO that can provide some of them. There's a mosque community that can provide some of them. That we are actually creating a system where we see a person as a person, right? But there requires this sort of transfer of information, this sharing, this sort of ability for people to not worry about Big Brother, so on and so forth. Do you think that is actually even a possibility in this world? It's in Mars, I hear from Imran,
yeah.
but I don't know if it's
Well, I mean, from a legal perspective, privacy laws are very, very tricky. I think that there will be a lot of pushback on that from political perspective. So yeah, I think that as you can see, just even with just the idea right now of you know, having people show their COVID registration card. I mean, people are resistant to the idea of a COVID passport even. So, and that's just on one simple thing like a vaccination card. So imagine having, you know, that unfortunately the privacy laws in this nation are designed like HIPAA is it's, you know, as you, and there's such a requirement right now in every sector. You know, I'm sure you get the privacy disclosures from every, like your credit card company and your insurance company, like your car insurance company. They you know, that to overcome that is a big hurdle. I think it's just it's a political issue that I feel that, you know, to you know, to overcome that is, you know, we can lobby for it, but it's still something that, and that's why we have this problem. So, you know,
Sister Shazia, I would like to ask you a question that, you know, even though we talk about all these privacy here, actually, right? Your data is right now sitting in India and probably in Ukraine or somewhere, basically.
Yeah.
They can create one more Shazia and ship it here, basically. Which, you know, and I'm telling you right now, because they have been calling you, they have been telling you that you know the IRS is after you, and you know you have done some stuff, basically. So they have all the data. I mean, we have lost the data, basically. This privacy thing is all, I believe that's all BS, actually, because all these things have been outsourced and shipped to India and Ukraine, basically.
Yeah.
Right. So sorry for my conversation, but
no.
But this is politics, actually. We are talking totally politics, right?
Yes.
So I think we should get out of that mentality, saying what privacy are you talking about? Is all these healthcare are not operating in India? Then if they are operating in India, then they have your data. What kind of a privacy are you talking about then here?
I mean, absolutely. And the thing is that health equity is achieved through health policy, and health policy is based on public health laws. And that is the key. We have public health laws to address, you know, discrimination, housing discrimination, and so many other things. There must be public health laws that address, you know, the sharing of data, and that, you know, that's how you know, that's where it comes in. So health equity, health policy, you know, bring in the public health law to facilitate the data sharing, you know, because it is. And what is that based on? It's based on public policy. And just like you know, public policy is for the betterment of the community, for safety, so this becomes like it should become a matter of public policy, that healthcare should be, you know, healthcare data should be accessible to, you know, across the different you know, across the spectrum between the community, the health, you know, the healthcare providers and the community and the patient, and that has to be integrated. But like I said, it's all based on, you know, introducing public health laws that will address that.
I want to pick. We might switch topics in a second, but I want to pick on this for one more round here, and let me be provocative for a second. So I was part of a health leadership executive, whatever, leadership group, and there was a CIO of a hospital who gave a presentation, and so this presentation was basically like this. So it was a short video. I don't know if he got it from somewhere else or he helped create it. Basically, it was you might have seen it, some of you might have seen it, but this is basically a call from someone to like a pizza delivery service. And the guy says, okay, you know, I want to order, you know, a pizza, a large pizza, and so, you know, this is how. So the person says, okay, where do you live? And he says, I live on this street. Says, okay, well then what? And so he looks at that household and says, okay, that household is here, so now there's a delivery charge. It's going to take us more time to get there, right? Okay, and then that's household. That's what's 4 people in it. 3 have diabetes. 1 has this. Okay, then the healthcare system is integrated. So it's okay. Well, look, if he eats a pizza, he's going to have diabetic control issues. So now I'm going to increase the price because of diabetic control issues. So now pizza's not cost you $10, it's cost you $25. And then he looks at, okay, well then, there is some other sort of profile the person's taking the pharmacy data. He didn't fill his statins for his whatever else it is. So now he's going to eat cheese pizza. It's going to cause a health problem. He never filled his statins. So we're going to have the penalty for not taking the medicine that would help you digest this pizza or whatever it is. So you go through this exercise where he says, well, we want to achieve health equity. We want to have, provocatively said that, we want to have no data sort of barriers. Well, then we should expect that everybody's going to pay a different price for everything because of your personal risk profile. Now, I don't know. I mean, as you said, Shazia, that might not ever happen here, but for healthcare, we can do that. You can triangulate those sorts of data, and would that be a world that we want to live in, right? That look, we want to make sure that the public trust here of healthcare resources are prudently, judiciously, justice informing, right? Have equity. So if you buy a pizza and you're not doing the right things, it's going to cost you more. And someone else who doesn't have that same risk profile, it's going to cost them less.
Awesome.
So what
can
do you
I?
want for that future?
Yeah. Can I? Sorry. Go ahead, Shazia.
No,
That was
go
for
ahead.
you.
Sorry. No, it's fine. Well, I mean, basically, I think that's the, that's the fine line you're walking. I mean, insurance companies are already using that kind of data, in how they're charging. I mean, it's based, they see patients who come in with pre-existing conditions, for example. So they are. I mean, you can't say that, unfortunately, they're sharing the data for, the wrong reasons. I mean, to penalize patients and make access to care actually more difficult because they're penalizing patients who do have, pre-existing conditions and diabetes and cardiovascular disease. So it comes down to it honestly the corporate culture and what it benefits the big healthcare companies. I mean, they're going to do what benefits them, and that's it. It is. It's political. It's economic. So
I think there was I read a joke somewhere that somebody orders a pizza basically, and the pizza guy says that what kind of pizza do you want, and he's ordered some cheese and heavy stuff. So says as well, according to your recent medical record, you cannot have this pizza because you are obese and blah 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 basically. So I think we are at that era actually, that everybody has that information through social media and everything, and everybody knows everything basically, But again, when it comes to the network talking to each other, I think that becomes the political issue, that the data cannot be shared. But all the insurance data is all in India right now, actually sitting in somebody's laptop, actually, right? And that is
I have to interject here. If you like, I feel like my heart is starting to race, to be quite frank. That's a huge reason I left such roundtables down to the communities, because and that's how I became actually a PCOR ambassador, because all what I hear is your own perspectives from your ivory towers as clinicians or public health policy makers. But patients in this discussion, all what they want is an insurance that is compassionate and takes their interest as their first priority. They want to be able to understand the type of information that you're telling them. They want to make an informed decision of to eat pizza or not to eat pizza. And they want to be able to be in a job environment that allows them to afford healthy diet, which we all can agree that it has changed a lot over time. And since the FDA approved a lot of processed foods, I don't think many of us are expertise at all in what healthy foods look like. It has become a discipline in its own. So if we want to go back to the national priorities for health and how PCORI wants to act, I really want to pick more on Courtney, since I am very familiar with Muslim leadership's roundtable discussions. I am really, really curious to hear what Courtney has to say. When you hear Muslims talking about PCOR utilization as a toolkit, how does that resonate with you? And how do you see it possible? How do you see us talking to each other after like historical burden and trauma and continuous marginalization of faith-based communities and racialization of Muslims. How do you see the PCOR tool actually reaching out to Muslims and trying to work collaboratively to bridge that gap?
So I think the important thing is when you're talking about PCOR and engaging with communities, you have to reach them where they work, live, play, sleep, worship in some cases. And from what I understand, at least through conversations at the eMarch symposium was about 2 years ago, you know, a lot of people talked about how in their mosque communities, there are those opportunities to not necessarily sleep, but to work, to worship, to hear information, to eat, and participate in community. So when that is the center of somebody's culture, often that can be the place that can then germinate that information and share that information where they can learn about patient-centered outcomes research. When you think about patient-centered outcomes research, it's a big word. I think Janice said earlier, she heard about it and she was like, wait, what? And the reality of it is, like, you know, it's really, when you break down what those 5 principles are, you know, that mutual respect, creating a chain of honest communication, then you can develop trust. Also, you know, if you think that I'm a person that you want to hear from, pay me for my time, respect that I'm a person who should be compensated for my own lived experience and lived expertise. I think that, you know, there have been projects, I shared a slide of projects that have also focused on other faith-based communities. And with that, the reality is that these are some people who may have also been marginalized for various reasons from being engaged in research, whether it be historical traumas or things that, you know, they may have read on a website. And so there's conspiracy theories around it. And so they're hesitant because, I mean, even with people and having vaccine hesitancy, there's some historical issue based in that. Like they didn't just make this up in their heads. And so I think, you know, the act of engaging communities and learning about research and learning how their voice matters in research and learning how they can actually impact research by having, you know, having that empowered sense of being, communicating with their physicians or their clinicians, communicating also and developing research partnerships, communicating with researchers and letting them know, like, you say you want to do this in my community, but my community doesn't need that. We need this. I've been a part of previous projects or programs at PCORI where we worked on building research partnerships. And there was one researcher who had this idea in his head. He's like, I'm going to go in and I'm going to fix this community. I'm going to do this and this and this. And then he started talking to members of the community. And the reality was the community didn't want that. And he had to change his mindset after hearing from them. But thank goodness he was open to it. You know, after hearing from them, like, oh, the direction of my project should go this way, not this way, because these are the people that I say I want to help, and this is what they want, and not what I said I initially wanted to do. So to sum all that up, I think that, and having worked with Dr. Padela and Fatima on creating the initial mosque PCOR toolkit, you know, I really did begin to see the importance of the work that was being created out of that project, because it was going to reach a subset of people that PCORI hasn't necessarily reached in the past. When you look at our portfolio, there are not that many projects that focus on Muslim communities. And so this project was one that was just the stepping stone to allow other Muslim communities to then become involved with PCORI and allow their voices to be heard and allow their voices to help to shape what our ultimate national priorities as well as research agendas should be.
If I may, just for closure, I really hope, and of course I have this on my action items, I really hope that some revision of the national priorities of PCORI would be more intentional about the word inclusion. And I think that's what's missing in most of the platforms. We're lucky to have diversity in the healthcare industry and exchange. We do have some equity to an extent, at least the efforts have started, but I feel like the problem is if I'm not invited in, as you've mentioned, whether it's compensated, monetary or non-monetary, I just feel like the word inclusion is missing a lot, and that kind of lacks the invitation of marginalized communities to come in. When you live so long in an echo chamber, it's very hard to articulate your concerns, I think, after a while. So that, hopefully that would be part of the action items that we can come up with after this roundtable. Thanks a lot, Courtney, for your answer.
Sure, and I do appreciate that comment. PCORI has created a diversity, equity, inclusion statement that is on the website. And I think it's really valid when you say like that, you're reading through here and you're not seeing that. So it's up to everybody here and everybody listening to challenge PCORI to live up to what it says it wants to do and what it lists on its website. You say you want diversity, equity, and inclusion. We don't see that reflected. You need to reflect it. So thank you for that comment.
Thank you both.
If I could just add, what would leave Courtney with a thought, and in the next half hour, whenever chance, if you want to address something like that. So, and I see that there is Janice has alluded to that comment as well, and in my head, there is a health data that's out there, which is very clinical, and then you have social determinants of health data that's there, which resides in the social services domain, and these two data sets do not match. And an IT challenge has always been, especially with the clinical systems that are out there, they don't capture that data. They don't capture the essence of the true human being. They may capture the essence of the human body, but they are not there yet. The well-being we talk about is we're adding the mind, body, and the spirit, all the three dimensions to it. So how does PCORI, within PCORI's priority, I know there is a integrated health learning system objective there. So how would it have it in the, how does PCORI envision of rolling that out? That's it. And you don't have to answer it now. I think other people are probably going to have similar questions coming up.
I'll just say though, Fatima, to that point, and so for the audience, very shortly we're gonna stop this roundtable and then field questions from the chat. So if you have questions, please put them in the chat. I have the full screen version here, so I haven't looked at the chat from your end, but please do that, and then I'll start going through those questions. But I do want to mention to your point here, Fatima. So we have, as a physician, I'm saying, we have now, and I'm the vice chair of research in emergency medicine, and we have a dashboard for social determinants of health in our ER and our EPIC system. And we just had a consensus conference at the Society of Academic Emergency Medicine that we will do intakes on the social determinants of health, right, for individuals, and we have some programs to intervene upon them, right? It used to be that you just have a social worker deal with homelessness, right? When you figure that out, and that has a problem, that has some, for example, you figure that out at the end of the visit, hey, someone has no place to go, as opposed to this sort of intake form that, no, we want to understand where you are in the social determinants. The question always for that science has been, well, there's been two things. One is, do we actually have interventions to address all these social determinants? Because if you start collecting data on something and then have no way to address that, that's a problem. Just like, say, I start doing breast cancer screening, but I have no way to connect to someone who will be able to take care of you should you have breast cancer. That's a problem. Similarly here with social determinants. And the second has been an infrastructural problem, right? So within healthcare systems, and I'm saying systems, not just hospitals, oftentimes we don't have the providers to be able to address those things, right? And particularly now in COVID-19 pandemic, we've had huge amounts of attrition and people leaving the profession who are facing and servicing these sorts of things. So I think that there is an understanding of that. And let's take about this spiritual histories. Like, who takes spiritual histories? We've been talking about that for 40 years, but that's even missing in the social determinants of health, right? So sometimes we can't even partner with religious communities because we don't even have that within our platform. So we have ways to go, but I want to say the awareness is there, Fatima. Perhaps the capacity doesn't exist. And as you said in your clinic talk earlier today, right? We would need that, hey, this is the clinical domain, and let's triangulate with the social domain, and let's triangulate with the other domains, right, together, and have a multidisciplinary team that addresses the whole person. I think your project is amazing because of that. I think we're all trying to move there. Well, we all know that is a, that's like a spaceship type of challenge. They're using that idea we're going to Mars. It's like that kind of challenge we have in front of us. But it is, I think, 4:01, and I had promised Asna that I want to stop this round and start taking some questions, and we can go back and jump on each other's comments if you'd like. So let me just change the screen on my end to see what questions there are in the chat from the audience. And please, everybody, just put your comments there. I'll field them, your thoughts there. Okay, so Yeah, I think Beverly Rogers asks, how much of data sharing is held back by hospitals because of payment from insurance, CMS, and others? So anybody on the panel have insight there about how much data sharing is held back because of that?
I actually do not want to answer the question. I want to challenge the impact and the value of it first.
Of the data, okay. Do people from the healthcare side believe that data? Dr. Hassan, is that data valuable?
I'm on both sides of it now because I've been on the operations side for 5 years, and now I'm on the insurance side. And I would tell you that, I mean, certainly the data is available. The concern that would exist, I think, is how is the data then interpreted and then analyzed? Certainly on a hospital side, as we would be mandatorily reporting our quality measures, we'd always have sort of the quality measures come out, and then you have the talking points that come with the quality measures in case your quality measure is not a 5-star. So that way you can kind of speak to the community as to why you're where you're at. And I think that becomes the pitfall of being able to have publicly reported data that's there from a quality standpoint and being able to speak to that if you don't have necessarily the arrogant hospital look, which would be medical sophistication to be able to analyze the data. And I recognize the arrogance is present in that statement, but I do think that that's going to be something that hospital systems would certainly be leery of, being able to have full transparency and sharing of data if they don't have some degree of context with which to address the data that's shared.
So there is some reticence at times, right? As what you're saying from the hospital side. I recall, though, that in certain areas of health, maybe they're mandated to do that. So maybe I'm wrong, but maybe the group here knows this. But I know I work a little bit in organ transplantation, and so there is this notion that you have to disclose how many procedures in certain types of transplantation you're provided, how many deaths there have been at your hospital from transplantation. So is it just that by sector you can say that, but not totally? Or is there a different context?
Awesome. It's a great question. And I'll come around to it and incorporate the previous question by Beverly as well. Let me tell you, the data, the patient data that hospitals own is incredibly valuable. Hospitals are getting offered literally multi-million-dollar deals, and they come through my office. We've been offered multi-million-dollar deals by multiple parties for access to healthcare data, especially in Emory, in the Atlanta area. Our healthcare data is very valuable. And the healthcare data comes from various communities, from all different types of communities. And there is risk in sharing it. So there are, like you said, Aasim, under HIPAA, I'm not a HIPAA expert, but for healthcare operations, for patient care, for things like billing, that is not prevented at all with a business associate agreement or other type of what's within HIPAA. Healthcare data, as Imran mentioned, is freely flowing every day, all the time. But it should be, in those cases, directly related to the patient, to the care of a patient, or to administrative concerns regarding patient care. What's interesting is that, however, like in your example of the personalized pizza price, right? There's actually been some research on this by Halverson and others, that minority groups have greater reticence to share their data because of their lived experience. They want to participate in research, they want to share their data for research purposes, but it is not very hard to re-identify data, frankly, even if it's been de-identified, with publicly available data sets, with 2 or 3 pieces of information. 80% of the US population can be identified at an individual basis. And that poses risk to individuals. So, for example, in my system, currently, down to my department, we have not been interested in sharing data except for research, right, under an IRB or with proper de-identification. But that's increasingly more and more difficult because the scale of data that's being requested and that's required for a learning health system is not hundreds or thousands of records. It's tens of thousands, hundreds of thousands, millions of records, and de-identification at that level is very difficult. So this poses a regulatory challenge. HIPAA, our subject protections regulations that prescribe IRB approvals. We're pre big data AI machine learning regulations, and there's a tension here. There is an obligation to share the data for the purposes that we're describing, so that we can make sure that the data's benefit is realized for populations, including minority populations, including populations like the Muslim American community. On the other hand, people are terrified of making mistakes, of further stigmatizing a community or further endangering a community, frankly, of creating more barriers to access because an insurance company or some other company may, and I'm not saying it's nefarious necessarily, but if they're profit driven, they may say, hey, this population or this zip code or this demographic may get a higher rate than others. And it's very possible, just like we've been talking about personalized medicine, to do personalized targeting in a way that hurts people. So there's a real conflict. The data is incredibly valuable. I know, because I've seen the deals that are coming across our office's desk and what they're offering. Huge amounts of money. There's a whole new market. There's data aggregation markets that have created it is a multi-billion-dollar market already. So there's no question in the data. In fact, a healthcare record, because it's immutable, is worth about $40 on the dark web per record. You can change your credit card number, you can change your bank card number, but you can't change your medical record, and that's why it's so much more valuable. But there's incredible risk with that data, and so that's the challenge that we're dealing with. Is we want to make it available. It's valuable. We want to unleash the power of the data while protecting individuals. And frankly, we're just not there yet. It's not a trivial task.
Thank you, Nabil, for that. Janice had a question. So I want to say one thing, and then I'll take Janice. I think you have a good comment that I'll see if people can comment too. But I was in. I think it's interesting how we think about data here versus other countries. So there are some countries where have socialized medicine, right? And for them, people don't own their data, right? It is the provider of healthcare services or the state that owns your data, right? And so they have huge management structures, and you don't have a right to privacy if you're participating in the healthcare system, right? We have a right to help you be healthy or whatever else it might be. So I think it's interesting. Maybe it's an American phenomenon, and not necessarily just American, but there's a different cultural phenomenon here than in other countries where there's, where there's a notion that this is not yours. And then I'll just add, Islamically, this is a question, right? Are you your data? Do you own your data? Do you own your biomarkers? Is that part of you ontologically or not? So I'll leave that for another conversation out today. Janice talks about the Gravity project that she's involved with, that's creating some standards for social determinants of health. And she says, I'm concerned that individuals who are new to social needs data collection don't realize the importance of keeping data confidential, as you just mentioned, Dr. Safdar. And so MOUs need to be developed and have been developed to exist to exchange SDOH, social determinants of health data. So Janice, you can comment on this, but are you suggesting that we should have a similar gravity to these social determinants data as we do to ailment data? Is that what you're suggesting, and that's what the project wants to do? Does the panelists agree with that? Like, so we shouldn't, if I have diabetes, God forbid, and that's protected, my PHI, the fact that I also have been divorced should be part of PHI now? Is that it's sort of like kind of relationship? Do you all agree? What do you all think? Silence. Well, I'm not divorced, but being married does increase your life expectancy, just so you know. There's a direct link. So that should be protected?
Honestly, my personal opinion is yes, all that data should be integrated and should be housed at one location, so that we can know exactly how to address the different disparities within a particular community. There is no other way we would be able to do that unless we really have those things. But yet that is true. And I think this is more of a social responsibility question as well. And in fact, social responsibilities lies within all of us, and social medicine or having that, again, because healthcare is so profitized and resides in a for-profit world here in this country, it poses a challenge. But really, this is a social enterprise.
Thank you, Fatima, for that. I'm just going through the chat. There's a question by Rebecca Johnson. Are medical schools and universities the best places to coordinate health and social determinants of health research? What do you all think as panelists?
I think I would like to take that one because I am a strong believer actually in medical education, and I like to pick up medical students before they get infected with cynicism and ethical erosion. So it would be really, really nice to hold them early on in their stage and show them that they can really have a butterfly effect, learning more about the holistic view of the patient, really having patient interests first, regardless of what context they function in. There's nothing wrong actually with being for profit. It's just how we utilize any platform. Even non-for-profit organization can be pretty much profitized, but it's a non-monetary manner. So I really think also that we think always of assets as financial or fiduciary. So I really love your question, Dr. Johnson, and I tend to agree. I'm really inclined to believe that academic medicine or academic settings, not necessarily just universities, where the education is a core value, where you get like a current and ongoing learning process for clinicians or healthcare workers, I believe that that's where you should start introducing the concept of social determinants of health. And I really like to adopt the suggestion by Dr. Padela. Maybe we want to replace the word research with knowledge generation, since unfortunately research has also been misused as a word. I'd have to say that it has become very intimidating and somehow alienating a lot of the people who just think about clinical practice as privatized or profiting. So maybe like kind of couple both concepts when we are introducing social determinants of health and say, hey, we want to bridge gaps, we want to generate knowledge, and research is one of the ways that we want to do that. There are so many things that we have seen in this conference that have been utilized to bridge gaps that were not really sophisticated tools of research. And that's my answer.
Thank you for taking that Dr. Sundar. So just to complete, Janice to say yes, she does agree that in her view, social determinants of health should be protected information as well. And let me push back for a second, Rebecca, if I might, as a moderator, ask or share this idea. Not that medical universities or schools shouldn't be a place, but they presently are not. Right? So if you think about training, the first experience that a student has as you're indoctrinated into medicine, after you wear the white coat, is to go dissect a dead human. That's your formative practice in an anatomy lab, to figure out what this anatomical function and dysfunction, anatomical anomaly led to dysfunction, led to the death perhaps, right? Or just to learn the anatomy. You're not meeting people who have lived 90 years, 100 years. You're not meeting with other, so you're in this sort of reductionist modality of trying to figure out the malady as opposed to experiencing the joy of people who are being healthy. And I think that formative experience has long-term effects about how you think about medicine, generally speaking. So I think the idea of what we're supposed to, the goals of medical training would have to change to allow for not just electives in social medicine, but really this notion that we are about health and producing health in society. not about finding disease and eradicating disease, right? Because we're finding disease and want to eradicate it as opposed to creating health in society. And just to call, I have no plug. I have a plug here, but it's not. I have no affiliation. But the Michigan State University, which has the largest medical school in Michigan, both DO and MD, they've redesigned the medical curriculum as part of a project, a grant-based project, in my understanding, where they now have medical students, for example, go and spend time with social workers, with chaplains. Like, that's what they're doing, to understand that there's a human being that you're caring for, not just the rotation with the physician, right, or with the clinical attending, but you're spending time as part of the social care team, as part of the chaplaincy team, as part of some other team, right? And so I think we have to think about that as well. But I don't want to take too much time speaking. We have about 10 minutes left. I'm gonna go back and address one last question, I think, from the chat here. Actually, it was just a comment. So now I'm gonna let the panelists here. So each one of you can have 2 minutes or so to comment on the priorities here, add anything that you wanted to add that I didn't allow you to add for my failure, my shortcomings, and then we will close the panel. So you can go in order on my screen, perhaps. And I'm going to start and call you out, and you have about 2 minutes to share any final thoughts for us. So Imran Khan, you're the first person on my screen here.
I think what we need to do is, from the masjid perspective, that we need to have good leaders in the masjid as well, actually, to understand, how this healthcare can be integrated with the community, right? And they should be, and masjid is your community, basically, right? So that's why that integration is very important. And plus I think the integration of these different entities that we have, has to happen in order to get the patients, as we are talking about patients, right? I mean, the patient owns their own data, basically, right? So if there has to be a consent from the patient, when the patient consents that, yeah, you can operate, basically, right? So you have the consent. So you don't have to get a consent from any other hospital that, to share this data or something like that. It's already been done. So I think it's more of a politics thing. But if we can address these issues, I guess we can definitely be in a situation that we can move forward with a good system, actually, integrated system. Thank you.
Thank you, sir. Dr. Hassan?
So I would start by asking our masjid leaderships to really take better advantage of some of the community resources that are available to them they may not know about, and being able to define what they don't know about. That recognizes that we have to understand that each mosque is likely at a different stage of maturity in terms of where it is on the journey of community integration, as well as just even understanding what PCORI work means. I think that once you recognize where you are in that journey, then being able to further engage with your local healthcare resources, I think, is going to be important. So that way you can somewhat have a discussion about what your own needs and demands are of your local healthcare system. And as you're working with them, you'll be able to ask, this is what I want, this is how you can help me. Because remember, the hospital has an incentive here. The hospital's incentive is to make sure that we are leveraging community resources to reduce readmissions, number one, but then also to raise community health so we can keep people out of the hospital, the most expensive place to be. So I think being able to have some degree of community partnership is present therein. And I think really being able to even leverage that to ask for data at a local level is important. I really think that it's important to get folks to understand something that I learned from a Baptist preacher. And that is, if you're not at the table, you're probably on the menu. And so you need to have a seat at the table.
Unless you're vegetarian. Thank you so much, Dr. Al-Saad.
Thank you. So I'll start with Dr. Hassan's last statement. So when you are on the table, make sure you are practicing intellectual solidarity. I think that was a very commonly missing ingredient whenever I am part of these spaces. Everybody can actually learn something valuable from you, as much as you can also learn something valuable from someone else. That mutual and bidirectional learning experience between us and people has to take into account different worldviews, and transparency is a very important piece in there. Make sure that we all examine our agendas, what kind of self-service this has to us when we are on the table. Are we truly having patient-centeredness in our mind? Are we really having the customer clearly defined? And who are the stakeholders that I want to shake hands with or shake for the sake of those patients? So I really think that practicing more intellectual solidarity can get us to converge so many parallel channels into one great pool of service for the community wellness. And thanks for this opportunity.
Thank you, Dr. Al-Saad. Shazia, Doctor, please.
From a legal perspective, of course, as I mentioned before, public health law is a great determinant of public health policy, and then, of course, health equity comes from that. And we talked a lot about how we don't address these things, but I wanted to bring up recently Illinois passed the Illinois Healthcare and Health Services Reform Act, and it has a lot of provisions in it that actually do address health equity. It has provisions allowing for maternal and fetal services like doulas and home health visits for mothers from marginalized communities. These are mandated, covered by Medicaid. It also has a community health worker reimbursement from Medicaid to train and certify. There's going to be a board certification for community health workers. And one of the other important mandates in this act is implicit bias training for all healthcare workers. And I think that is very important, because I know Dr. Al-Saad mentioned that is something that, the bias, that's there in the healthcare workers that are there. They don't recognize, people coming from backgrounds different from them, and what their limitations are, and what their, what kinds of challenges they face. And I think that, having training, that implicit bias training, which Illinois has mandated for all healthcare workers as part of this act, is so, there is, and other states need to come on board and look to this as an example. And hopefully that will help with addressing the health equities.
Thank you. Dr. Sufder?
Yeah, thank you. And, I agree with all the comments that were previously made. First of all, I want to thank you, Dr. Padela, and Fatima and Courtney for organizing and leading. I've been reviewing and embarrassed that I had not previously reviewed the toolkit that you had put together for MOST-based patient-centered outcomes research. And it is incredibly valuable. It has a really strong framework, but we've got a long way to go to spread that word. And get it to mosque leadership, and get it to not just mosque leadership, but to the members, of mosques, and those, frankly, that are not routinely mosque going, which is a significant part of the American Muslim community, as you know. And there's a long way to go to that, because folks are not necessarily comfortable or familiar with research. As was mentioned earlier, mosques are at all different levels of capacity, right? Some are struggling to provide basic services, while others, do have the capacity and can lead. So I think, I believe in building on what's already been done. Looking at your report, it's got a lot of great information, obviously very thoughtful and very well put together by you and the rest of the team. And so I want to thank you for that. My focus would be to think about how we can get that word out, use that material that you've put together and make it more digestible for others. I'm afraid I might inadvertently being volunteering myself for getting a follow-up phone call or email. So I'm going to be quiet before I get myself into more trouble.
Well, I think you were going, because Fatima's next. And so here you go, Fatima, there you go.
Yes, absolutely. I love this. Thank you. I really am so humbled and so honored that all of you joined us and joins to be a part of this discussion, because without these candid discussions from all different types of the stakeholders in the community, solutions will not be possible. So I think it's really one of the things, as everybody has put together or has put together their thoughts. I'm thinking there is this the government resources that are already out there, the payer industry, the healthcare guidelines and the regulations that are mandating payers to act in certain ways. They're also mandating the healthcare administrators and the clinicians to act in certain ways. And then you have the community need that actually faces the community-based organizations like us. And as a connector, I'm simply thinking that all I need to do is align these up. That's it. The solutions are already in place. I see actually the tools that are being generated, that's already in place. And I really think that PCORI is a phenomenal tool. It is a beautiful, in fact, a very, very powerful tool to align these things up. And my preference would be, and PCORI actually announces these priorities. Not only it announces, they kind of direct their research agenda, or the generation of knowledge, I want to say, in the direction of community health needs. So I think following that line of thought would be the way to go for a nonprofit like me. So that's what we would be doing. We're simply taking the needs from here, looking at the tools of PCORI, and aligning ourselves up in the direction. We don't have much to do.
Understatement of the year. Thank you.
Thank you.
Courtney Clyde, your 2 minutes. Thank you, by the way. I have a thank you and we'll close, but any comments, any thoughts here to share with the group before we close?
Sure. So as I've alluded to before, or actually said outright, if you have any thoughts related to the national priorities for health, again, there is going to be a public comment period. These, as they are written currently, will be going to the Board of Governors to then adopt in, I think actually maybe later this month. There's a board meeting later this month. I'm not sure if it's on that agenda or the next one. But after they are adopted, there is another public comment period for the development of PCORI's ultimate research agenda. Some other things to think about. I did mention the Engagement Award Program, and that's something that Dr. Padela was funded under, that Fatima was funded under, and that Michael was funded under, along with Imam Sharif. And so with that program, some of the outcomes from projects can be the development of research topics or the development of research agendas. So these are some things to consider. If you don't see yourself represented in what we have created in or what we've published as our research agenda or our priorities, there are ways for you to enter into, becoming a part of that. So I do put the onus on all of you to also keep PCORI correct. In, as Dr. Al-Assad mentioned earlier, she didn't see inclusion or inclusivity in the priorities or anything explaining what they are. And so, PCORI does have its own DEI initiative. And when we say that we have a DEI initiative, but something is missing, we talk about diversity, we talk about equity, but inclusion is not there, call us on it. We are a public organization, and we do have to respond to public comment. So thank you again for all your work on this project, Fatima and Dr. Padela. It has been challenging at times, but also it is a pleasure to see the ultimate outcome and know that your work will continue. When we talk about sustainability, sometimes it's just about planting seeds and bringing people together. But it sounds like there will be some great conversations that will continue beyond the project period, and perhaps some additional partnerships that will be developed. So thank you for allowing me to be part of that.
Thank you, Courtney. So it is my honor to now close our 2-day symposium. It's truly been a delight to be part of this project and to watch the ways in which we have come together. We've learned from one another. And really, Courtney, actually, thanks to you and PCORI for allowing us to continue to dabble in this area. to gain some literacy and increase our own knowledge that we might share with others. And to all the panelists for your great insight. We do hope, as Courtney already mentioned, that we will continue these conversations after today. It doesn't end today. This is another beginning for conversations to improve the health of our society. I know I focus a lot on Muslim health work, but that's not all we mean, right? Or the Muslim dimension of health work. So I mean that for all of us in all societies. So all these things that we live, all this society that we live in, we're responsible to it. So I don't want to take time since people expect us to end at 4:30. It's 4:32. I do want to thank you all for all the attendees. I hope that you found this beneficial. As Fatima said, we will make these videos fully available. Please join the website and you'll see that there will be things that we roll out there. And then we hope to engage with all of you, those who attended, those who spoke, those who just participated intermittently, and those who were there the entire time in whatever way, in whatever capacity we could. So with that, I will end and thank you. Oh, I do want to say, I want to thank all the people who were not profiled here. I know that Fatima, your entire team has been working tirelessly for the last 96 hours, right? All hours of the night, because I'm getting emails at 3 in the morning with PowerPoint slides to review. That I know that they've probably not slept in 4 days. So I hope that tomorrow you get a day off, right? And you can at least recuperate before Monday. So thank you for those who we don't know, but they're behind the scenes for all the hard work that you did. And again, I appreciate all the work you're doing, and may God help us come together for good purposes and leave for good purposes. Thank you all. Take care. Bye.